I'm Carol Runyan, Emeritus Professor at the UNC Gillig School of Global Public Health. I first gave this presentation at the SAVIR, Society for Advancement of Violence and Injury Research meeting in Chapel Hill in April of 2024 and was asked to record it again for SAVIR. So that's what I'm doing today in October of 2024. I titled this talk, Standing on the Shoulders of Pioneers, Looking Back to Envision the Future. And I did that to help us all try to remember, particularly those of you newer to the field, how we got to where we are today, what some of the events and people were who helped us build the field to the point that it is today. Some of you will recognize all the faces on this screen. Some of you may not know any of them. At the end, you'll have a chance to test yourself and see how many you can identify. Many of them I will identify during my talk. Please understand, though, that this is not an exhaustive presentation. I won't be talking about everyone who contributed to the field. I'll be coming from more of a public health perspective and give less attention to acute care, rehabilitation, or biomechanics, and just name some of the key leaders along the way. Winston Churchill is quoted as having said, "The farther back you can look, the farther forward you are likely to see." And I think this is an important reason for looking at the history of our field, or any field for that matter, so that we can learn both about the successes of those who came before us and also the mistakes they made, and hopefully that we can avoid making in the future. It's also important, I think, to remind us that change takes a long time and rarely happens on a straight pathway. So I think it's really important that we think about the future as we think about the past. I would like to thank and acknowledge several people who helped me put this presentation together, and also state that I have no conflicts to declare. I'm retired and not paid by anyone. So just a reminder of where we are today. I'm going to give a few examples. Today we have a lead federal agency, the National Center for Injury Prevention and Control. It funds both internal and external research, including, at the time I put this presentation together in April, 9 injury control research centers. That number's increased since April. And more than 20 core violence and injury prevention programs in state health departments. We have the Indian Health Service that funds close to 30 tip-cap sites in Indian country and provides multi-level training programs for local providers. We have professional organizations, SAVIR, and as well as Safe States and the Injury Control and Emergency Health Services section of the American Public Health Association. And we have training, core competencies I'll talk about later for practitioners in the field. There are workshops that are going on all the time, and courses in some, although I would argue not enough, schools of public health focused on injury and violence prevention. And we have our 15th World Injury Conference that was held in New Delhi in September of 2024. Some more examples. We have many safety policies and practices, including in the fire safety realm, fire safe cigarettes and smoke alarm ordinances. Motor vehicle safety, including various forms of passenger protection, graduated driver licensing, blood alcohol limits, and so on. Worker safety provisions to protect child workers and workers in all industries with specific equipment requirements and labor requirements. For violence prevention, we have red flag laws in many states and a number of initiatives to encourage safe gun storage. And to prevent childhood injury, there are a number of policies and provisions, including medication packaging, toy safety, child abuse reporting. And to protect participants in sports and recreational activities, we have concussion protocols helmets, and many other examples. But many of the things listed on this slide, including the slide before, didn't exist just a few decades ago. We have made a lot of progress in the last few decades, which is what I want to talk more about. So looking on this graph from 1968 to 2020, and using data from CDC Wonder, I plot the age-adjusted injury fatality rates per 100,000 population. And you see the blue line is unintentional injury, the green line suicide, and the red line homicide. What's most noticeable is the decline in unintentional injury that happened through the 70s, 80s, and 90s, largely attributable to reductions in motor vehicle crash deaths. But there has been an uptick in recent years that has a lot to do with the opioid epidemic. And then some changes in both suicide and homicide, with suicide still being resulting in more fatalities than homicide. So how did we get here? So let's take a trip back in time, starting in the early 20th century, where the term accidents was used to describe injury events. And that really didn't change until the 1960s. Accidents were attributed to misbehavior, to human error, to carelessness, to being accident-prone, or just being acts of God that can't really be controlled. In 1913, the National Safety Council was created with a focus on teaching safe behavior for both home safety and worker safety. And they based their recommendations on producing annual reports using data that they could call largely from mortality data. Today, they still produce an annual report called Accident Facts. Hugh DeHaven was one of the early scientists looking into injury forces following his own crash as a World War I pilot, in which he survived, but the other occupant in his plane did not. And he wondered why. He was trained as an engineer and joined the faculty at Cornell University and began to try to figure that out. One of his early papers, Mechanical Analysis of Survival in Falls from Heights of 50 to 150 feet, was first published in the journal War Medicine in 1942 and has been reprinted in Injury Prevention if you want to see it there. He did multiple studies that addressed the forces in crashes and later designed the three-point seatbelt. Based on his research, he made the statement, "The level of safety which we accept for ourselves, our wives, and our children is on a par with shipping fragile, valuable objects loose inside a container." Moving forward into the 1940s, two researchers at Harvard are important to recognize, for their work significantly shifted the thinking about the causes of accidents. Ross McFarland, a psychologist, developed studies focused on how humans interact with their environments, focusing particularly on motor vehicle crashes, airline crashes, and in work settings. This is basically the beginning of the field of ergonomics and a focus on human factors in traffic safety. Also at Harvard, Dr. John Gordon, an epidemiologist who had studied infectious disease, applied the concepts of agent-host environment, what we know as the public health model, to the accident problem. This paper, published in 1949, reported on the epidemiology of accidents as a public health issue. Gordon inspired William Haddon, one of his students, to later develop these concepts further. I'll come back to Haddon in a moment. So in the 1940s and 50s, public health was beginning to give more attention to accident prevention as an issue. And you see here, given that I gave this talk in Chapel Hill, I show you scenes of Chapel Hill in the various eras that I'm talking about. In 1945, an American Public Health Association subcommittee conducted a survey of some 300 state and local health departments to find out what they were doing to address injury prevention. As a result, they called for expansion of attention beyond the 9 states that had state-level programs, and constructed specific recommendations of what those programs should address, with a focus largely on home safety. The attention to the issue was also driven in part by data from the National Safety Council that allowed people to see the numbers and compare war casualties from World War II to deaths and disabilities on the home front. Though I'm not entirely sure of the accuracy of these specific numbers, it was a motivating piece put forward by the Metropolitan Life Insurance Company and published in the American Journal of Public Health in 1946. Also in 1946, the U.S. Public Health Service created an accident prevention program, which later became the Division of Accident Prevention and supported poison control centers, supported efforts in traffic safety, home safety, recreational injury, and emergency services, as well as pushing professional education, research, and training and fellowships for graduate students in injury control. In 1950, the American Academy of Pediatrics created its Committee on Accident Prevention, which urged pediatricians to include more preventive messages in their regular anticipatory guidance. And in the 1950s, the W.K. Kellogg Foundation, which had a strong interest in child welfare and programs to support children, funded 10 state demonstration programs on injury prevention. While I can't be sure, I do know that one of Kellogg's own children died from injuries sustained during a fall from a window, which may have been the impetus for this program. The 1950s and 60s saw continuing work on engineering aspects. In 1954, Colonel John Stapp, a physician and flight surgeon in New Mexico, strapped himself into a rocket that propelled him to a speed of more than 600 miles per hour, with the purpose of testing the limits of human tolerance. He experienced a force that broke his ribs and his wrists and even temporarily blinded him, but it fortunately resulted in no permanent injuries. As a result, he was nicknamed the fastest man on Earth. Also, engineer Carl Clark in the early 1960s began experimenting with designs for airbags for crash protection in both cars and airplanes. He personally crash tested an airbag system by lying down in a large box between 2 airbags, and then had the box dropped from different heights to test whether he would be injured. Fortunately, he wasn't. Later, Clark developed an early version of what I refer to as airbag underwear, designed to protect older adults who fall. This technology has since been further developed in multiple countries and has included creation of airbag bike helmets and hip protectors for motorcyclists. Moving on into the 1960s, here's a photo of the Chevy Corvair, which some of you may remember. It's the car that prompted the book by Ralph Nader called Unsafe at Any Speed, which he published in 1965, opening with the line, "For over half a century, the automobile has brought death, injury, and the most inestimable sorrow and deprivation to millions of people." In his book, and later congressional testimony, Ralph Nader contended that cars were being manufactured without all the benefits of safety that had already been developed. Within a year of the publication of the book, Congress passed the National Traffic and Motor Vehicle Safety Act, and LBJ signed it into law. It created the federal agency that would later become what we know now as NHTSA, the National Highway Traffic Safety Administration. Meanwhile, as Nader was working on his book and giving congressional testimony, William Haddon, who had been the student of Gordon at Harvard School of Public Health, became health director in the New York State Health Department. In 1964, Dr. Haddon published his book, Accident Research, Methods and Approaches, with sociologists Edward Suchman and David Klein. The book compiled a rich collection of papers on various aspects of injury prevention, and it articulated the importance of doing rigorous scientific research and using good methods for evaluation in creating and testing sound approaches to interventions. In 1966, Haddon was tapped by Johnson to head the new Traffic Safety Agency, a position he held until he became president of the Insurance Institute for Highway Safety in 1969. He held that position until his death in 1985, publishing several seminal papers that have helped shape the field ever since. Shown there on the right, one contained the 10 countermeasures for prevention, published in 1973, and another, the Haddon Matrix, in 1980, as well as many other papers. If you haven't read these seminal papers, you definitely should. In 1966, the National Academy of Sciences published a new report jointly from its Committee on Trauma and Committee on Shock. The report called for improvements in emergency services, improvements in autopsies, development of a trauma registry, and emphasized the importance of prevention, stating that the long-term solution to the injury problem is prevention. The report also cited the lack of funding to address the issue relative to other types of health problems, and called for a National Institute on Trauma, presumably thinking that should be within NIH. As interest in traffic safety began to increase, Pat Waller, a psychologist, was beginning her research career. She was one of only a handful of women engaged in traffic safety. Though primarily based at the UNC Highway Safety Research Center in Chapel Hill, Pat also had an appointment in the UNC School of Public Health, and with others there began to engage public health students in the issue. Her work at the Highway Safety Research Center was based on her understanding of behavior and was instrumental in guiding efforts to develop the graduated driver licensing programs. She also studied heavy trucks and other traffic safety issues throughout her career. In 1987, she and I worked together as she became the founding director of our UNC Injury Prevention Research Center, or IPRIC. Then, the following year, she was recruited to lead the University of Michigan Transportation Research Institute, where she worked the remainder of her career. That left me, a very junior faculty member, in command of our injury center. But thanks to some help from many colleagues, I was able to carry on. So moving on to some selected highlights in building the field during the 1970s, and another picture of Chapel Hill. The Public Health Service Accident Prevention Program was eliminated by Nixon in his administration, but his administration also created other agencies that were important to the injury mission. The Occupational Safety and Health Administration, or OSHA, was created at this time, as was NIOSH, National Institute of Occupational Safety and Health, a part of CDC, and the Consumer Product Safety Commission, CPSC. Also, NHTSA created FARS, the Fatal Accident Reporting System, and the National Electronic Injury Surveillance System, or NICE, was created at CPSC, allowing improvement in injury surveillance. Some other important federal legislation also came about during this time. Dr. Abraham Bergman, a pediatrician in Seattle, defined himself as a practitioner of political medicine. In his obituary this last year, the New York Times observed that, quote, cultivating ties to two influential U.S. senators from Washington state, he was unusually successful as a private citizen who influenced legislation. Dr. Bergman was instrumental in advocating for a variety of important legislation, including those listed here. The Flammable Fabrics Act of 1967, that was designed to protect children's sleepwear. The Poison Prevention Packaging Act of 1970, that was instrumental in reducing childhood poisonings. And the Sudden Infant Death Syndrome Act of 1974, which created funding to understand and prevent sudden infant death, as well as other legislative initiatives. Dr. Bergman also founded the University of Washington Injury Control Research Center in 1987, one of the original centers, along with his junior colleague, Dr. Fred Rivara. Another pediatrician, Robert Sanders, worked with his pediatric colleagues throughout the state of Tennessee, especially those who took care of the children of legislators, to gain passage of the nation's very first child restraint bill in 1977. News of this spread, and by 1985, all states had laws on the books protecting child passengers. A few other examples of pediatricians in this era who were instrumental in policy change are shown here. C. Henry Kemp, who first defined the battered child syndrome, advocated nationally for passage of the state child abuse reporting laws. He went on to found the Kemp Center in Denver, a renowned child abuse center focused on both treatment and prevention. Barbara Barlow, a pediatric surgeon in New York City, was troubled by the numbers of patients she was seeing who had fallen from windows in New York City apartment buildings. She developed the Children Can't Fly program and convinced New York City officials to require window guards. And Doctors Murray Katcher in Wisconsin and Ken Feldman in Seattle worked on the issue of scald injury, seeking changes for the standards for temperature settings upon installation of hot water heaters. These are just a few examples. Another giant in the field, Susan Baker, often referred to, at least in public health service circles, as the mother of injury control. Now in her 90s, she's still contributing to the field, stimulating efforts on product design as a means of increasing safety. Sue began her injury career in the 1960s, working with the medical examiner's office in Maryland, using epidemiologic research skills to understand the causes of fatal injuries. Her early work focused on child injury and on traffic crashes. She was supported and mentored by Bill Haddon and given funding from the Insurance Institute for Highway Safety. And early on, like Haddon, she stressed the importance of good research and focusing on environmental and product design and not relying solely on behavioral change approaches. I've been conducting oral history interviews over the last few years, and several of the people I've spoken with talked about how the conference that Sue hosted in 1982 was instrumental in their thinking about injury control and getting into the field and shaping their careers and moving the field forward. In 1984, she published the book, The Injury Fact Book, which was an important volume that reported the descriptive epidemiology of multiple different types of injury, giving novel demographic and geographic breakdowns to understand patterns throughout the country. To be credible as a female researcher studying aviation safety later on in her career, she trained as a pilot, just as Pat Waller had learned to drive 18-wheelers when she had studied trucking safety. Sue is the founding director of the Johns Hopkins Injury Control Research Center and trained scores of future injury researchers and practitioners. And at the conference in April, I pointed out that among the several hundred people in the audience, I was guessing that a large number of them had either been trained directly by Sue or by someone whose professional lineage included Susan Baker. She was a major force in bringing our field along. So moving into the 1980s, and I put this picture up for a conference in Chapel Hill. One can't be thinking about the 1980s in Chapel Hill without thinking about Michael Jordan and basketball. But also, it does relate to this talk in that after Jordan's father was murdered, he provided funds to help support the development of the Jordan Institute at the UNC School of Social Work to support work on families and on violence prevention. Dr. William Faggy is an important figure, a giant in the field, both literally and figuratively. He's, I believe, somewhere around 6'4". He became the director of CDC in 1977 after having been active internationally in the effort to eradicate smallpox. When I spoke with him during the last year, he described how he began annually to put a line item in his budget to support work on injury prevention within CDC, given his awareness of the data on injury morbidity and mortality. But each time it was removed from the budget as it worked its way through the system, with comments back that injury and violence were not public health responsibilities, that the responsibility resided with police and with transportation. But Faggy didn't buy that. He kept trying. Between 1979 and 1981, as some of you may remember, there was a serial killer in Atlanta who took the lives of nearly 30 young children, referred to as the Atlanta child murders. And CDC began to help the police use epidemiologic methods to understand the patterns in these crimes. This is part of what stimulated Faggy to hire Mark Rosenberg in 1983 to head up a new violence epidemiology branch. From a tiny office that I've seen in the basement of the main CDC building and a very limited budget, Rosenberg was tasked with developing a research program on violence. Initially, the unit was encompassed within the new division of epidemiology and control within the Center for Environmental Health, which at the time I first visited there in the 80s was based in Quonset huts on the outskirts of Atlanta. It eventually grew into what we know today as NCIPC, National Center for Injury Prevention and Control. Mark was the first permanent director of NCIPC starting in 1994, after Dr. Stuart Brown had overseen the development of the first 2 years of the unit. To study the issue, in 1985, the National Academy of Science Institute of Medicine created a committee to investigate the problem and appointed Faggy as the chairman. Their report was issued in 1985, Injury in America, a Continuing Public Health Problem, which many of us old-timers refer to as the IOM report. It defined injury as a public health problem whose toll is unacceptable, and stated that injury was the last major plague of the young. With Faggy being careful not to steer the recommendations toward CDC, the committee ended up recommending that there must be a National Center for Injury Control within the federal government, not unlike that report that had been issued back in 1966. And they selected CDC as the best home. And how this came about is an interesting story. Congressman Lehman from Florida had the chairmanship of the committee that oversaw appropriations for transportation. And at the time, one of his family members was seriously injured and seeking care in a Washington hospital, where Dr. Ayoub Amaya was a caregiver, a neurosurgeon. Amaya had been a consultant to the IOM committee in putting this report together and handed a copy of the report to the congressman. And what ended up happening was that Lehman was able to facilitate the transfer and appropriation of $10 million through the Department of Transportation to CDC to fund the initial CDC injury program in 1986. Based on the Injury in America recommendations, the program started by funding 5 injury control research centers, starting in January of 1987, for a 3-year trial period. They were at Harvard, Johns Hopkins, University of North Carolina, University of Washington, and Wayne State University in Michigan. At that time, under that first funding, centers were required to address 5 key areas: epidemiology, prevention, acute care, rehabilitation, and biomechanics, which I will say was quite a challenge to do all of those, particularly for the level of funding provided. The program has expanded over the years with varying numbers of centers as the funding levels rose and then shrank. As of April 2024, injury centers were operating at Columbia, Emory, Johns Hopkins, Nationwide Children's Hospital in Columbus, Ohio, University of Iowa, University of Michigan, University of North Carolina, University of Pennsylvania, and University of Washington. But formally funded centers for which there was no longer sufficient CDC funding to sustain continue to operate at a number of the original sites where CDC funded the programs. And as I mentioned, since April, I believe 2 new centers have been added to the list. The 1980s also brought new books in the field. Leon Robertson, on the right, had been a colleague of Haddon's at the Insurance Institute for Highway Safety. Using his research skills as a sociologist, he conducted a landmark study questioning the efficacy of driver's education. Later, as a faculty member at the Yale School of Public Health, he published 2 texts on injury epidemiology. Pictured on the left, Julian Waller, a physician at the University of Vermont, was teaching preventive medicine and created a text to introduce students to the many different facets of injury control. Another important effort to recognize is the development of the Indian Health Service program. Though the program in the IHS and injury prevention had started in the 1940s, Rick Smith was appointed leader in 1984 and began reorganizing the program. He brought a background in environmental health and a perspective that was shaped in part by Sue Baker and Leon Robertson. And under Rick's long-term leadership, the IHS developed a number of programs, including a comprehensive model training program to enable tribal injury workers to use the latest methods in injury prevention in their communities. And through his leadership, and the agency developed funding programs to support injury prevention initiatives in communities, mostly rural, with very economically challenged environments, to address the injury issues specific to tribal populations. The 1990s also saw a rapid expansion in research as well as practice. During the early 90s, CDC started offering external research grants. This committee was either the first or one of the first grant review teams pulled together to review submissions. I will say we all looked a lot younger then. And the proposals back then were not submitted electronically as they are today, but on paper. And as we finished our reviews, you can see there the boxes that were put in the middle of this big square table, and we would toss the completed the proposals for which we completed reviews there in the middle in a rather cathartic and messy way. In 1992, the National Center for Injury Prevention and Control was formally formed as a center at CDC, a full-fledged center, whereas before it had been a program. And according to Rosenberg, this was in part due to the activism of trauma surgeons who threatened to advocate for shifting CDC's funds to NIH if the center was not created. So despite some internal conflict within CDC, the National Center for Injury Prevention and Control was established as one of the full-fledged CDC centers. Also the same year, the American Public Health Association was able to reform the injury section, which required having a certain number of members, and started to grow very rapidly from that point. I remember when I was first in the field in the 80s that all the injury researchers would meet at APHA and go out to dinner together, all 10 or 12 of us, and sit at one table. Today, the number in the section is well over 500. In 1993, Johns Hopkins Summer Institute was launched as a way to provide continuing education and for existing injury professionals, as well as to help train new professionals to do practice in the field. CDC released its National Action Plan also in 1993, laying out an agenda for the nation. And STIPTA, the State and Territorial Injury Prevention Directors Association, was created. It later became what we today know as Safe States Alliance. And in 1995, Barry Pless from McGill University created the journal Injury Prevention as part of the BMJ series of journals. In 1996, as things were continuing to grow in many ways, there was a setback, and all was not rosy. With pressure from the National Rifle Association and leadership by Congressman Dickey from Arkansas, the Dickey Amendment was passed. It forbade CDC from doing work that advocated for injury control. And though it didn't explicitly prohibit gun research, it was, in the words of Mark Rosenberg, quote, a shot across the bow, unquote, coupled with threats about removing funding from the agency if gun research was carried on. As a result, CDC virtually stopped funding any gun research until 2019, when the Dickey Amendment was rescinded. But other good things were happening during this era. In 1997, we at the University of North Carolina Injury Center hosted the first live dial-in video conference to a national audience of more than 2,000 from across about 40 states. This was well before Skype or Zoom, and people actually had to dial up to watch our live production that went on for about 6 hours in an auditorium at the School of Public Health. Also in 97 is when NCIPC began funding the core violence and injury programs in state health agencies. In 1998, SAVIR, Society for Advancement of Violence and Injury Research, was created, growing out of the National Association of Injury Control Research Centers. Those of us center directors with NACRIC, as we called it, wanted to be sure that the expertise that existed outside of injury centers across the nation could be brought together in an organization focused on advancing research in the field. And in 1999, that research was enhanced when, under the leadership of Lee Annist at CDC, the Whisker system was created, enabling easy access for health departments, researchers, students to understand and examine injury data throughout the nation. In 1999, there was another Institute of Medicine committee put together to review the progress in the field. Their report cited that there had been major accomplishments in the injury field over the past 25 years since the original IOM report had been issued. And they also made recommendations about where improvements could be made. They recommended improvements in surveillance. They urged collaboration among the ICRCs. They pushed for more research and practitioner training, and for research and policies addressing firearm injury. And also, they pushed for more infrastructure at the states, in the health departments, to push for prevention efforts. At this time, the literature was also expanding, and here's a selection of some of the key books that were produced during this era. If you haven't read them, I suggest you take a look. These were all important contributors to the development of the field. I probably missed some, but these are the ones from my shelf. And then I took a look at peer-reviewed publications over time, starting in 1974 and continuing to 2023, using the search terms unintentional injury, accident, homicide, suicide, child maltreatment, and doing a search on the web of science. What you can see here is the growth, one metric for measuring the growth in the field from the beginning over there in 1983 when CDC first formed its violence unit and brought in Mark Rosenberg, to the red, the first IOM report, the green, the funding of the initial 5 injury control research centers in 1987, the increase in the centers to a number of 8 in 1990, the creation of NCIPC as a formal center in 1992, and then the beginning of funding in 97 for state injury and violence prevention programs, and then later in 2000, the funding of 10 youth violence centers by CDC. So impressive growth as these initiatives took off. So now moving into the 2000s. And another view of Chapel Hill. And just a few examples. As I mentioned, in 2000 is when NCIPC created the 10 Centers of Excellence on Youth Violence. In 2001, SAVIR and Safe States worked together to develop the National Training Initiative, or NTI, which developed core competencies for the field. And we at UNC, as a part of that effort, were able to initiate the PREVENT program with CDC funding and later foundation funding, where over the 6-year period from 2003 to 2009, we were able to train more than 900 violence prevention practitioners from 44 states in the principles of public health and prevention of injury and violence. And in 2002, NCIPC drew on work from several different injury centers to develop the National Violent Death Reporting System as a part that's now available as part of the Whisker system. There's obviously much more to report that I have time for in this presentation, so I won't be able to tell you about Fred Rivara and his leadership in child injury and in leading the effort to get the National Institute of Child Health and Human Development to develop funding for injury. And I won't have time to talk about the work of David Hemingway and Steve Terrett and their colleagues in addressing firearm injury, or Susan Gallagher and her creation of the Children's Safety Network as a force in the field. I won't be able to tell you about Kathy Barber and her accomplishments in developing the Means Matter campaign to prevent suicide by firearms and medications. I won't be able to tell you about Billy Weiss, whose work in Los Angeles addressing youth violence was innovative and important. And I don't have time to tell you about Andrew McGuire's more than 30 years of efforts to succeed in ensuring that only fire-safe cigarettes can be sold in the U.S. 30 years. Remember that. I won't be able to tell you about Larry Cohen and his creation of the Prevention Institute as a force in injury prevention and policy strategies. Or about Andrea Geelan, whose leadership in applying behavioral science to prevention has been important for the development of the field. You'll have to learn about these folks and others some other way. But before I conclude, I want to bring you to some pearls of advice from pioneers in the field that David Hemingway published in Injury Epidemiology in 2018. You should read the article to see all of the advice that these leaders in the field put forth. I picked just a few of my favorites to present here. One is to remind us that the work we're doing is important in the world of people's lives. It's not just an academic exercise. We need to remember that this is important for people's lives. And we need to think creatively, taking risks as we try out new approaches. And as my ski instructor always used to say, if you're not falling down some of the time, or in this case, failing some of the time, you're not trying hard enough. We also need to remember that creating data without action is just dead information. We need to use that data to create interventions and take action. And in doing that, we need to engage with diverse fields outside of public health, learn their language, teach them ours, and work together to find solutions and to understand problems in the different types of communities where those problems exist. And as we develop our research, which we all know is in a very competitive funding environment, we need to think of other researchers as our colleagues rather than our competitors. While we have to compete for funding, we can work collegially with those in other institutions, and we'll make greater progress if we do so. Here, if you want to learn more about the history of the field, are some references that I would highly recommend. And then going back to the future, as we think about the future, looking ahead, what are some of the challenges and opportunities that we're likely to face over the next couple of decades? The ones that occurred to me, I put on this slide. And at the conference in April, we had a panel discuss some of these challenges and think about approaches to them. You'll have to do that on your own, and perhaps think of others to add to this collection. And as you think about them, I'd encourage you to think, are there other challenges or issues that you can envision? How can the lessons from the past inform the approaches to addressing these challenges successfully going forward? What mistakes from the past can future leaders avoid as you move the field forward? And how can you best engage a diversity of ideas as you seek solutions to these problems across diverse settings, diverse problems, diverse communities? And then back to all those pictures with the numbers on them so that you can test your ability to identify these individuals, 52 of them, who appear on this slide. The final slide gives you the answer sheet, but I encourage you to test your knowledge without the answer sheet. At the conference, we gave a prize to those who did the best in identifying these individuals. I hope that's been useful and that you will use what you learned as those of you newer to the field move the field forward over the coming decades. Thank you for listening.